allow you a very nice concentration of your treatment that will fall right into that stromal bed. As you can see here, this area of stroma looks very decentric, but when you start your treatment, it's fall perfectly in your stromal bed. And that is the fourth part. You need to avoid that type of thing that can happen during the surgery. You can see the ablation spot of the excimer striking on the flap edge. That will reduce not only the efficacy, but that can definitely induce part of the astigmatism that you can see after the surprising astigmatism that you can see after the surgery. So to do that, what you can do before your surgery is to look exactly at the distance between the pupil center and the corneal vertex, and you take this distance into account when you're gonna decenter your flap and when you're gonna extend and enlarge the diameter of your flap. You need to take that into account. So you make sure, according to the white to white, and that distance you need to decenter your flap has to be taken into account, so you can put nicely the flap into the place you have. You can see here the pupil center and the vertex of that patient. You might have the ability to decide between the pupil center, the vertex, or different area in between, or going halfway or three-quarter way. And you can see here, for instance, even when you have a nice large flap, you can peek toward the vertex and have still a very nice ablation that falls right into the stromal bed, just because you calculate in advance how to position at your flap. And then you have the topography. You can see that nice ablation. This is for hyperopic and presbyopic patients. So you can see this nice centration that is on the vertex, the red cross, and not on the yellow one that is the pupil center. Now the last tip is related to the target refraction, which is a big challenge. And you can see here that graph is a very classic graph of stability after hyperopic treatment. This is from Dan Renstein with a very large series of patients, more than 700 eye, with 2 years follow-up. And you can see that there is always that initial overcorrection, and then it regrets over time with a regression that is about half diopter within 2 years. So the number one thing is on the patient selection. You need to avoid those patients that having a very large accommodation spasm. So ideally, when you do the manifest and the cycloplegic refraction, you don't want to cross that 1 diopter difference in those patients. You want to tell them that there might be a transient myopic shift after the surgery, and this is fine. We don't want to correct that. That will go the way after the surgery. We used to say that when we see that overcorrection, the surgeon is happy and the patient is not, but it's a good sign for future success of the surgery. And you need to expect, when you target your patients, a regression that might be about half diopter within 2 to 5 years after the treatment. So the key message in terms of surgical curve is make large flaps, about 9.5, but obviously you need to check your Y to Y before, so you can adjust that individually. You have to get a thicker flap than one you do usually, so the flap will not mold that stromal shape and produce more dry eye in those patients. You want to center your stromal ablation toward the vertex position, so that will allow a better optical outcome. And for that, you need to get your flap more nasally, so you will match that stromal ablation, and you can increase the optical zone between 6.5 to 10 millimeter, because that might improve the clinical outcome and reduce the regression after the surgery. And as you finish, when you play with those challenging cases, you need to know how to handle the main complication of those patients, because that happen, and those complications you're going to see happen more in those surgery. The number one is intraoperative bleeding. If you want to do a large flap, you might have bleeding during the surgery, especially in patients wearing a lot of contact lens. So look, those patients, the flap is very nasal, but as soon as you lift that, you start to have bleeding right after the flap lift. So in this case, you want to, number one, clean that for getting a nice iris recognition. You want to dry also before the ablation. You want to make sure that the stroma will be dry as much as possible. And then you get your ablation, and after you finish, you want to constrict those bloody vessels, so you make sure that you won't have an induced DLK. You can use phenylnephrine, for instance. That's usually what I'm doing right there, and it works nicely, and you can increase a little bit the steroids after the surgery. The second one is, again, because of that hyperopic and peripheral stromal ablation, you might have a hit of the flap hinge, and that can result in an induced irregular stigmatism. This is a real case. You can see here, one of my colleagues did a PRK, and you can see how it struck that hinge and induced that irregular stigmatism. That's the area where the hinge was hit. So you want to make sure that you will protect either mechanically, as you can see here, you see the spot striking your sponge when you are parting the flap. So it's very important to do that, especially in hyperopic patients. But you can also rotate and schedule and plan your flap accordingly, so the hinge will not be at the area where the maximum ablation of stroma might be. This is for astigmatism, for instance, but you can obviously do that for any type of profile, and that will help to avoid the stromal hit, the stromal pulses striking your hinge. And finally, it's the retreatment rule. The number one we need to know is that patients with hyperopia might have more retreatment than patients with myopia, and there is this nice series showing up to a third of the patients that need a retreatment within 2 years after hyperopic treatment. So expectation needs to be set with your patient. The second thing is that when you select your patients for retreatment in hyperopia, especially in the higher number, because those are the ones that usually are more inclined to have a retreatment, you need to look at the epithelium. You can see that the epithelium after retreatment of hyperopia is obviously getting this donut shape, as you can see here. It gets thicker on the periphery where the ablation was, and it gets thinner on the top. And you want to make sure that this thinnest epithelium can still allow some additional thinning to avoid apical scar, because under a certain threshold of thinning of the epithelium, the cells start to break and release some cytokine that will create those apical scars. So if you want to make sure this patient might be a good patient for corneal retreatment and not any other either ICL or lens-based procedure, you want to make sure that the central part of the epithelium is not too thin before you retreat that patient. And finally, when you assess your patient before retreatment, in any case of suspicion of overcorrection, you want to rule out first any accommodative spasm, because it happens a lot in those patients, especially when they are young. So you can give them, there are many treatments for that, either some polymedical side like the 20-20-20 rule, some optical fogging method with glasses, or obviously the cycloplegic drugs like cyclopentalate or atropine that you can give to those patients for a few days, and that can help you release those spasms and go back to your target. So thank you very much for your attention. Obviously, if there are any questions, we'd love to answer, and thanks again for the invitation.
Thank you, David, for your presentation.